Welcome to Chapter 39, Nursing Care of the Child with an Alteration in Sensory Perception and Disorders of the Eyes or Ears. When you consider the damage that young children can do to their eyes and ears between falls and lack of coordination, putting things in. Not only do they put things in their noses and in their eyes, but it's very easy to see why some of the problems that they encounter would occur just because of the physiology, the anatomy and physiology. So if you look at this image, you see the shape of the orbital of the eye in an infant or a young child versus an adult. The eyeball space, basically takes up a whole lot more of space in the cranium. And so because it's such a large opening, it's easier to do damage, if you will. There's less bony protection because of the size. Visual acuity, it tends to develop from birth through early childhood. So you're going to see the reason why we do visual screenings as well to make sure that visual acuity is, advancing appropriately. Color is, generally the book says light-skinned babies are born with blue eyes, but ultimately the coloring changes as more pigment develops. And so the eyes may not remain blue, even though they may seem that way to start. And when you think about vascularization of how you see, through the retina, in peds, the retinal vascularization is not complete as yet. So there is a disorder that we must, keep an eye out for, no pun intended, as, the young child in the early few weeks grows. Variations in anatomy for the ears also helps explain why these young children are more at risk for developing infections. First of all, a good thing to know is that hearing is intact at birth. In fact, hearing is also intact in vitro. So be careful what you say to babies at a very early age as they grow. Say only positive things. Recurrent ear disorders can indeed affect hearing. If you're going to see, and you can see that simply by the anatomy of the eustachian tubes. Okay, there are enlarged adenoids as well as, the angling and the width of the eustachian tubes. That makes the ears more prone to infection, as you can see how in graphic B, the eustachian tube in a child is much more horizontal on a plane, if you will, versus the obtuse angle, which serves as a bit of protection for fluid to travel up and to accumulate. When a child is brought in, as with any issue that you're looking at, trying to get a health history to start with a child, you want to sort of inquire about, issues like, when did it start? What was the onset? How long has it gone on? Has there been a fever? Is there nasal congestion? Has there been any eye rubbing, ear pulling, pain? Is the child lethargic? Has they complained of headache? Now, obviously, some of these things are subjective only. Mom can obviously address certain things if the child is nonverbal. Things like lethargy and behavioral changes if the child is nonverbal. They can't really explain, do they have a headache? You can see if they're rubbing their eyes or pulling their ears. But those are the kinds of issues that you're going to begin with in taking a health history. You also want to know things about family history. Is there a history of hearing impairment? If there's a, history of ear deformities, prematurity, right? What was the age of the child when they were, when they were actually delivered, their gestational age and then delivery? If there are any genetic issues, because you're just seeing the child potentially for the first time, and so you're going to be dependent on this information from the caregiver to give you some insight as to what you're going to be dealing with. Once you're done with the health history, you go on to the physical assessment. So, where do you begin with your physical assessment, your physical exam? Well, you begin with inspection and observation. So, really, you want to know if the child uses eyeglasses, corrective lenses, or a hearing aid. And then you want to observe the eyes, and you're going to note their positioning and symmetry, the presence of strabismus, nystagmus, and squinting. The eyelids should open fairly equally. Okay, and failure to open fully is termed ptosis, and that's what you see in this image here. The young girl above, her picture on the right is basically after surgical intervention. Um, Note in the child if there's any variations in eye slant and the presence of epicanthal folds. You're also going to be looking for eyelid edema, right? What is the color of the sclera? Is there any discharge or tearing? Are the pupils equal and are they reactive? And are the shape, like the pupillary equality as well as the size and shape of it? Okay, do you see any abnormalities in that sense? Then you're going to be looking at testing the eyes, okay? You're going to check for extraocular movements. You're going to check to see if the eyes can actually move, right, into the different fields, to the left, right, up, down. Those are important assessments. You're checking to see if the pupils respond to light. When you shine a light, do the pupils react and do they equally react, okay? You're going to look at the symmetry of the corneal light reflex. With symmetry of corneal light reflex, you're basically looking for strabismus, basically. You're looking to see if the eyes line up, if there is symmetry between, the left and the right eyes, and if in fact they are lined up appropriately. In the red reflex test, you basically are looking for any abnormalities in the back of the eye. Okay. Then you're also going to be doing an age-appropriate visual acuity test. It's going to basically be your Snellen test, which is like an eye chart. And it could be letters, it could be images. When it comes to the ear, you're going to be needing an otoscope and you're going to look into the ear and you're going to note any presence of cerumen, any discharge, if there's inflammation, if there's a foreign body in the ear canal, because little kids can put things in their ears. You also need to make sure that you're looking at the tympanic membrane. And by doing so, when you visualize it, you're looking at its color, the important landmarks, what the light reflex is like, and also if you note any scars, bulging, retraction, or even perforation. Now, there's also tests that can be done for the ears, which, as you see here, there is the Weber and Rhine test, and those check for sensory neural or conductive hearing loss. We'll discuss that a little bit further. There might be audiometry testing. Maybe some of you have seen that in school. That's a bit more extensive, but something as easy as a whisper test, where literally you are checking to see if the child can hear what it is that you are saying at a certain distance on, both sides of the head. Now, when you think about common laboratory and diagnostic tests, your book has a chart. It's 39.1, and it lists culture of the eye or ear, discharge that comes from it, tympanic fluid culture, which is generally painful because you've got to aspirate fluid, through the membrane. And then there's tympanometry, which I included a little picture here, which ultimately is a probe in the ear canal that measures movement of the eardrum in response to air and sound. Okay. Common drugs that are used, well, you're thinking you might have ear drops, you might have eye drops, and you might have systemic, antibiotics or oral antibiotics, right? So you might have antihistamines, okay, where you have allergic conjunctivitis, right? And those too might be topical drops. There are analgesics. You might have an ear infection. You might have an eye procedure. Sometimes there might be narcotics that are prescribed. So these are basically the common drugs that you're going to see often. Additionally, when you think about medical treatments for eye and ear disorders, your book also has a chart, 31.1, that discusses some of these that are, pretty simple. So everything from a warm compress, for the eyes to potentially corrective lenses that might be in need for refractive issues, maybe patching the eye in the event that you need to strengthen an eye. There might be eye muscle surgery. There might be eustachian tubes that are placed, like pressure equalizing tubes. There might be hearing aids that are needed. There also might be cochlear implants. These are what you're going to see commonly for these types of, disorders. Now, let's talk about some of these types of infectious diseases of the eyes. You can see that there's conjunctivitis, which is the infant on top. You can see how crusty the eyes are and reddened. There's a nasolacrimal duct obstruction. The eye can get pretty swollen, and you think about the lacrimal ducts with the tear ducts, basically. There's the eyelid lesions that we're going to be discussing as well, chalazions and blepharitis. And then there might be a flat-out infection process, which results in a periorbital cellulitis. Now, conjunctivitis is basically inflammation of conjunctiva, and it can be infectious, allergic, or chemical in nature. Viruses or bacteria can cause, some of these infections. And ultimately, when you're looking at the most common bacterial cause, it's Staphylococcus aureus, which means you can use antibiotics. In newborns, chlamydia trachomatis and Neisseria gonorrhea are more common causes. Allergic conjunctivitis can result from exposure to particular allergens. So when a bacteria or virus comes in contact with the bulbar or palpebral conjunctiva, they're recognized as foreign antigens. And remember, we've talked about this antigen-antibody immune reaction. Well, inflammation results. Okay. When you see what happens to the eyes, mast cell and histamine mediators are activated and inflammation in the eye occurs, and thus you're going to see pervasive redness. When you get a health history on a child, you're going to note that there's going to be redness, edema, tearing, discharge, maybe some like itching of the eyes. And you basically are going to ask like the parents the same kind of questions. When did this start? Is there a family history of allergies or atopic dermatitis? When it comes to the nasolacrimal duct obstruction, basically you're looking at stenosis or a simple obstruction of the nasolacrimal duct, and this is apparently common in about 6 to 20% of newborns and infants. Therapeutic massage can in fact help, okay? And if there's a secondary bacterial infection that's suspected, antibiotic ointments could most likely be employed. You might need a a culture of the eye drainage to rule out if it's conjunctivitis or a secondary bacterial infection. But in most cases of nasolacrimal duct stenosis, there's a resolution that spontaneously, by 12 months of age. There is a picture in your book of nasolacrimal duct massage, and it gives instructions on how that would work. Periorbital cellulitis is a bacterial infection of the eyelids and tissue that surround the eye. And, bacteria can gain entry to the skin via an abrasion, laceration, insect bite, foreign body. You want to be careful also because you want to protect the eyes. And, the bacteria produce either an enzyme or an endotoxin that initiates that inflammatory response. And thus you'll see, that periorbital swelling can be something that creates, basically closes the eye. We'll talk a little bit about some of those eyelid lesions in a little bit. Now, let's go back to the signs and symptoms of conjunctivitis. There's a table in your book, 39.1, which are basically types of conjunctivitis, bacterial, viral, allergic. And it goes into an understanding of what kind of discharge you might see, what other findings you might have, if there's eyelid edema, and basically what treatment is given. Disorders of the eyelids and how to manage them. Well, here I included pictures of, at the bottom you have blepharitis, and working going up on the right, you'll see that that is a chalazion. Um, you also then have an ordeolum, which is a sty. And I included at the very top a picture of what some of those glands are that are involved that create some of these problems. Okay. So again, if you have any infectious processes that become, infected, like sebaceous glands, usually there's a bacterial infection and that gets into one of these glands, and thus you have these issues. And generally, they are treatable with topical antibiotic ointments. Simple nursing management would require hot, moist compresses, the potential use of an antibiotic ointment, and ultimately the chalazion will resolve spontaneously. And if it doesn't, well, it might require some minor surgical drainage. So how can you prevent some of these issues? Well, encouraging the child not to rub or touch the eyes, rinse the child's eyelids periodically with a clean washcloth and cool water, because, sometimes if you're trying to teach them how to wash their eyes, they may not necessarily do a very good job. When kids come in from outside, make sure they wash their face and their hands, and make sure that they, basically shower and shampoo before bedtime so that during sleep they don't inadvertently end up like introducing an allergen, into the eyes. Now, aside from those eye infections and disorders, what about eye injuries? Well, unfortunately, as I said, eyes there's a lot of damage that can be done to eyes. You think about how soft they are, the bony protection is, there's just so much. Otherwise, it's like wide open to stuff ending up in there, like cuts and lacerations, blunt trauma, which can result in black eyes. Um, Here in this chart, 39.2, it lists a couple of eye injuries, lacerations, corneal abrasions, foreign body getting into the eye, and there are some of the nursing assessments that you should be considering when you do when you basically take care of these patients. Now, when do you need to send somebody to an ophthalmologist or a specialist? Now, I don't have all the pictures here because, some of them this was already probably a little bit difficult to look at, but traumatic hyphemas, that is what the image you have of the blood-filled cornea, if you will. The MRI shows a blowout fracture. There's a red arrow that's showing where the base of the orbital, section of the skull has sort of just like, well, it's basically gone, if you will, or fractured. And so you have displacement there. The bottom picture is a ruptured globe. Um, and, all of these are emergencies. Thermal new chemical injury, well, splashing of acid or bleach or, um, you know, those kinds of injuries that can occur, obviously without even knowing people are near frying stuff, heat, embers that get into the eye. Sometimes there are animal attacks, and we've seen some disfigurement because of animal attacks. Lid laceration, if you think about, child falls on sharp rocks and the lid gets lacerated, you want to be concerned about the eye itself, the eyeball itself, the globe. There might be corneal abrasions, stuff gets in the eyes that abrades the cornea, or there might be corneal penetration, or there might be a foreign body embedded in the globe. And these are all images I did not want to show you. Hopefully you will never see them. But all of those require specialist care. Okay, now let's get into visual disorders. Refractive errors basically occur when light that enters the lens does not bend appropriately to allow it to fall directly on the retina. Because from the retina, if you remember, that is what transmits image information to our brain so we understand what we are perceiving. In refractive errors, you're thinking about, as this picture shows, myopia, which is nearsightedness, or hyperopia, which is farsightedness. And you can see where the light ends up falling. In myopia, it falls very close, okay, to the lens, and in hyperopia, the light ultimately goes even far beyond the retina. Okay, one doesn't even fall on the retina, and one goes back and beyond the retina. In astigmatism, you're thinking about the cornea's curvature, which is uneven, and it results in an irregular quality of vision because the light rays are refracted unevenly. So you can see in the image to the right on the bottom what that looks like with how a person perceives an image. You can see that it's the refraction of light creates a problem, and so there are sort of it's like shadowed, if you will, like shading for each of the objects that are viewed. In strabismus, you're basically looking at alignment of the eyes, and strabismus actually refers to the misalignment of the eyes. It's common and apparently occurs in up to 4% of the population. And the most common types of strabismus are exotropia and esotropia. Exotropia, as you can see, are where the eyes turn outward, and esotropia, they turn inward. So because of this unequal alignment, visual development in each eye can be difficult, and it may proceed at different rates. Double vision may result, which is diplopia, and vision in one eye may actually be quote unquote turned off by the brain to avoid that double vision. So it's common that many infants have strabismus intermittently, but it usually resolves 3 to 6 months of age. Then you have amblyopia. Now, amblyopia refers to poor visual development in the otherwise, normally structured eye. It develops within the first decade of life, and it's a problem if it remains untreated. Now, this is as a result of musculature. The brain is not working together with the eyes. So vision is reduced, and while the eyes are trying to focus differently because of the differences, one eye ends up being stronger than the other. And so thus you get something that's referred to as a lazy eye. I just realized that I heard myself say that amblyopia has to do with musculature of the eye. That's not correct. It has to do with the nerve conductivity. There is the nerve pathways between the brain and the eye aren't properly stimulated, and so the brain favors the one where the pathway is intact. So the brain favoring one eye means that there's going to be favoring, and thus the other one sort of becomes, if you will, lazy. Now, I could not do a GIF in this particular lecture, but rather a GIF file for nystagmus. But nystagmus basically refers to a very rapid, irregular eye movement. And, it kind of looks like a bouncing. I guess that's what it's referred to as in your book. It may occur in children with congenital cataracts, but the most common cause is a neurologic problem. It is difficult for the brain and eyes to communicate when the eyes are in continuous motion, right? Makes sense. Thus, visual development can be affected. And, kids with this might have to see not only an ophthalmologist, but possibly a neurologist. We also have infantile glaucoma. Now, infantile glaucoma is an autosomal recessive disorder that is more common in interrelated marriages or relationships. It is often associated with other genetic disorders, and it occurs in about 1 of 10,000 live births. So, what characterizes infantile glaucoma? Well, there's obstruction of aqueous humor flow and increased intraocular pressure that results in large, prominent eyes. Vision loss may occur as a result of corneal scarring, optic nerve damage, or most commonly, amblyopia. Now, unlike adult glaucoma, in which medical management is the first step, therapeutic management of infantile glaucoma is focused on surgical intervention. Surgical intervention. Infantile glaucoma is treated surgically via goniotomy. Okay, that's removal of obstruction of the aqueous humor, and laser surgery might be used. So really, as a nurse, you want to know if there's any, history of infantile glaucoma or genetic disorders in the family. You want to note if, mom says that infant keeps rubbing the eyes or keeping the eyes closed. You're going to look in the eye for corneal enlargement and clouding, and we're going to see a little bit more of this in another slide. Then you also have the potential for congenital cataracts. And congenital cataracts is an opacity of the lens of the eye, and it's present at birth. Sensory amblyopia will result if the infant goes untreated. So, at times the infant is fitted with bilateral, contact lenses if necessary. So when you are asking families about, your assessment, what questions about that, note if there's a history of a lack of visual awareness. Okay, when you use the ophthalmoscope to examine the eye, the red reflex will not be observed in the affected eye. There is also retinopathy of prematurity, which has its own slide. We'll be talking about that, and also visual impairment, and we'll be talking a bit more about that. Vision impairment is in children, and basically it refers to an acuity between 20/60 and 2200 in the better eye on exam, but we'll basically talk about that in legal blindness in a second. So what are some of the therapeutic managements for visual disorders? Well, if you look at the picture of the young girl with amblyopia, in order to strengthen the weaker eye, you put a patch on the better eye, right, in order to train the one that's weaker. And, there might be acerine drops that are used also in the better eye. Additionally, you're looking at prescription eyeglasses or contact lenses, right, to correct hyperopia or myopia. You can see in this picture a convex lens that helps to correct the hyperopia and a concave lens that helps to correct the myopia. With strabismus, there might be vision therapy, and there also might be eye muscle surgery that is, that is prescribed as a plan of care. Now, again, here's that infantile glaucoma. Okay, you're looking for photophobia, tearing or conjunctivitis, eyelid squeezing or spasming. The infant keeps the eyes closed most of the time. And there's corneal enlargement and clouding, if I said that already. And then the eye looks enlarged. Okay. Here we have risk factors for retinopathy of prematurity. Now, I mentioned to you that retinopathy of prematurity had to do with vascularization, or rather a disorder of the vascularization of the retina. And if you think about when retinal vascularization begins, it begins basically in the fetus at 4 months, and it progresses until completion at 9 months or shortly after birth. Therefore, a premature infant that is born with incomplete retinal vascularization is at risk for the development of retinopathy of prematurity. So new vessels continue to grow between the vascularized and non-vascularized retina. So if you look at these images, because I looked it up so I could put this in here, if you see the retina in stage 1, you see where that black line is, and you see where that line of demarcation is, okay, as to how far the extension of vascularization occurs, it goes into progressing where that wide line thickens and widens. Then you see new blood vessel growth into an area that it should not go. You notice that it's actually away from the retina, and that ultimately results in the retina becoming detached partially detached until it's fully detached. And, changes in oxygen tension resulting from hypoxia, in oxyhemoglobin dissociation curve changes. When you have that adult blood transfused to the premature infant, these are all issues that play a role in the development of ROP. Complications of ROP, well, they include myopia, glaucoma, and blindness. So, in general, what you're going to see when it comes to the development of the risk for developing visual impairment, prematurity is one factor, developmental delay is another, genetic syndrome could contribute to that, family history of eye disease, African American heritage, previous, serious eye injury. Now, this is not just for infants, right? This is all of peds, okay? All of the pediatric population. Diabetes, HIV, and chronic corticosteroid use. These are all issues that need to be monitored when it comes to vision. Now, what exactly is visual impairment? I kind of mentioned what that is. It's basically an impairment in the ability and acuity to see. So I included this chart to sort of help you understand that in visual impairment, you can have an acuity, anywhere between 2060 and 2200 in the better eye on exam. So what exactly are those numbers again, if you can recall? The 20 is the distance at which a normal person, which an individual can see. However, that 60 is at the point where a normal person can see that image. So if an image is 60 feet out, okay, that means that the individual needs to be at 20 feet in order to see what someone sees at 60 feet. So with the 2200, somebody needs to be standing 20 feet away from an object because that's where they see it best. But that is for a person who has normal vision, they can see that very same image at 200 feet. I hope that makes sense. I don't have a live audience to see if you understand that. Legal blindness, okay, that is a term that's used to refer to vision of less than 2200 or with peripheral vision less than 20 degrees. So remember, less than 2200 would be like you see on this chart, 2400, right? Because then that's less than 2200. 2200 is less than 2070 is less than 2020. Okay? I hope that helps in understanding that a bit. So what are some of the signs and symptoms of a potential visual impairment? Well, at any age, if there's a dull, vacant stare, in infants, they do not fix and follow. They don't follow the eye. They don't make eye contact. They seem to be unaffected by bright light, and they do not imitate facial expressions. In toddlers and older children, well, maybe they rub and shut and cover their eyes. They squint. There's frequent blinking. They hold objects close or sit close to the television. They bump into objects. They head tilt or they forward thrust. Okay? They put their heads forward. Okay? That means that they tilt their head or they put their head forward. So there is going to be teaching involved when you think of some of these disorders. It might require that there's eyeglasses that the child needs to have. There might be contact lens uses that the child needs to have. And this is, corrective lenses, if you will, ultimately in helping the child to sort of view the world. And really, it's for safety as well. This is huge in the event that the child is potentially blind or the impairment is so profound that the child is considered legally blind, even though they might be able to make out, shadows and barely make out shapes. So you're thinking about supporting the child and the family, promoting socialization, development, and education. If you think that the child has to be hospitalized for any reason, well, you got to make a plan to appropriately care for the child. If they've got a hearing, well, we're going to get into hearing, but visually impaired children, you have to, they don't know when you walk into the room necessarily if they're, sleeping or distracted or not sleeping, but if they're, have their back turned and they can't see, you need to get the child's attention. You have to use the child's name, let the child know who you are, all before you touch them, right? You want to help the child to be as independent as possible while maintaining safety, discuss activities, and obviously this is all depending on if it's age appropriate, okay? Okay, let's go into otitis media because there's a fair bit to this. Now, otitis media is defined as inflammation of the middle ear with the presence of fluid. There are two types. There is AOM, which is acute otitis media, and there is otitis media with effusion, OME. AOM refers to an acute infectious process of the middle ear that may produce a rapid onset of ear pain and possibly fever, while OME refers to a collection of fluid in the middle ear space without signs or symptoms of infection. Then you want to consider chronic OME, which is OME lasting longer than 3 months. Then you also have otitis externa, which refers to inflammation of the external ear canal. Now you can see that I have pictures of all of them, and I just wanted you to take a look at the, anatomy and physiology, if you will, and also the presentation of what it looks like, the tympanic membrane. So now that you see that, let's talk a little bit about what the patho is of acute otitis media. Now, acute otitis media is very common. It results from either a bacterial or a viral, infection of fluid that's in the middle ear. And infants and young children are susceptible, as we discussed, because of the short length and horizontal positioning of the eustachian tube, but also because they have limited exposure to antigens. They don't have a fully, built immune system. And so when you think about how, frequently kids, they're constantly coming in with ear infections, it is due to, those factors, if you will. Now, what is the patho of acute otitis media? Well, generally you see an upper respiratory infection that makes, the pathogens make their way through the nasopharynx up into the middle ear space, and the fluid gets infected. Now, if there's a viral infection, there's not going to be any antibiotics given, and it's usually going to resolve on its own. However, if it's a bacterial infection, well, then you're going to look at potential use of antibiotics. Once the infection is cleared, fluid will still remain in the ear space, and that might occur for some time. Now, again, this is because of the positioning of the eustachian tube, and it makes it difficult to drain back into the nasopharyngeal space. So, you're going to see that some of the complications of the acute otitis media are hearing loss, expressive speech delay, because if you don't hear, you can't speak, you can't acquire speech, tympanic membrane perforation, even intracranial infections, including bacterial meningitis. So when you consider that viral causes of AOM resolve spontaneously and do not require antibiotics, you want to also consider the fact that in order to determine that if it's bacterial or viral, how do you do that? You can't always puncture the tympanic membrane to get a collection of fluid. So there are some guidelines that your book goes over in order to determine if there is the need for antibiotics. If antibiotics are prescribed, remember you need to teach parents about completing the course of antibiotics as prescribed. As you can see in your book, Table 39.3, it's basically a chart for treatment recommendations for acute otitis media. Box 39.2 also lists risk factors for acute otitis media, and you'll see there are things like daycare attendance, there's family history, crowding in the home or large families, immunocompromise, poor nutrition, presence of allergies potentially, absence of infant breastfeeding. Okay, you'll see what all of those are. Now, you want to also consider the pain management. So what do you give them? Well, you're going to give analgesics such as acetaminophen and ibuprofen, and potentially to give them heating pads or ice packs in place to the ear because it can help. There might be numbing eardrops such as benzocaine. When considering otitis media with effusion, well, that may take several months to resolve. And, ultimately you're looking on education and monitoring for hearing loss, helping the parents understand that certain meds that they might be requesting, antibiotics, corticosteroids, decongestants, they've not been shown to hasten the resolution of it, and thus they're not recommended. But children should be rechecked, every couple of weeks to make sure that, in fact, what the status of it is. Additionally, you have to monitor for hearing loss. And when OME is persistent, the primary concern is its effect on hearing, because that also impairs language development and language acquisition. Communication patterns have to be adjusted because when you have a child with OME who may have hearing loss, you make sure that you do certain things in your nonverbal. For example, speaking to them face to face, turning off background music or the television, use visual cues, speak clearly, and you might have to advocate for the child to request preferential classroom seating. Another option might be having the insertion of pressure equalizing tubes into the tympanic membrane. And these tubes tend to stay in place for at least several months, and they can, in fact, fall out on their own. There's a picture of it I have on, I think, on the next slide. But you want to recognize that even though they have tubes and fluid is adequately draining, the middle ear can still get infected. The positive thing is if there's excess drainage, the infectious material can, in fact, be drained from the ear. Otitis externa is basically a swimmer's ear, if you will. It is defined as an infection and inflammation of the skin of the external ear canal. And you can see in the picture that sometimes there is drainage. Swimmer's ear is a result of moisture in the canal that allows for pathogens to grow. It can be painful, and so managing the pain is important. Warm compress or heating pad to the affected ear helps. There might need to be an antibiotic or antifungal ear drops as prescribed. And there is a chart, teaching guidelines, 39.2, which basically outlines preventing otitis externa. Basically avoiding the use of cotton swabs, headphones, earplugs should be worn when swimming, and ultimately you want to prevent any additional complications to occur. Here you can see a pressure equalizing tube that's been placed, and as I said, they will, fall out, on their own. But as you can see here, children with OME who are at risk for speech, language, or learning problems may be referred for evaluation of hearing earlier than a child with OME who is not at risk. And if you recall, when I was discussing children with behavioral and cognitive and learning, developmental disabilities, those are the kind of children that you would want to make sure that their hearing gets checked in order to get them sorted out and treated much sooner to help with all of these issues that may get even worse if they're not taken care of. Next, we're going to be talking about levels of hearing loss. As I mentioned earlier, infants are born with a sense of hearing that's fully developed. And again, language development in infancy and early childhood is really dependent upon adequate hearing. And even the fluctuating hearing loss associated with intermittent bouts of, acute otitis media can hinder language development. Now, hearing loss can be unilateral or it might be bilateral, and the extent of hearing loss is based on the softest intensity of sound that is perceived, described in decibels. And here you can see basically an outline of what normal, mild loss, moderate loss, severe loss, and profound loss of hearing, how it's measured. And hearing loss can be acquired or it can be congenital. And congenital hearing loss affects 1 to 6 infants per 1,000 live births in the U.S. Now, there's also delayed onset or acquired hearing loss that can be either conductive, sensorineural, or mixed. And here you can see the difference between disruption of sound. Conductive hearing loss results when transmission of sound through the middle ear is blocked, it's disrupted, as in the case of OME. Now, sensorineural hearing loss is a result of damage to the hair cells in the cochlea. Now, those help along the neural pathway, the auditory pathway, to send messages to, the brain as to what it is that it's hearing. And sometimes you can have this mixed hearing loss because it can be a problem of both conductive as well as sensorineural issues. So how do you ultimately protect, individuals? Well, you want to increase the use of hearing protection devices. You want to potentially reduce the proportion of adolescents who have elevated hearing thresholds, listening to concerts and being in crowded areas where people speak at loud, in loud voices. You also want to increase screening and the proportion of newborns who are screened for hearing. You want to have that no later than age 1 month. You also want to have at age 3 months audiologic evaluation. Nursing assessments are going to, involve basically, depending on the developmental stage, different elements. For an infant, if they, wake only to touch, but they don't wake to sound, they don't startle, they don't turn to hear or to look at sound, they don't babble, they don't progress with speech. For a young child, the child doesn't speak by age 2, communicates only through gestures, doesn't speak distinctly, prefers solitary play, doesn't respond to the telephone ringing or a cell phone ringing or a doorbell, and mainly focuses on facial expressions. With older children, they seem to do poorly in school, they seem inattentive, they ask for statements to be repeated. And ultimately, at any age, if you have someone who speaks very loudly, sits too close to the TV, responds only to moderate or loud voices, these are all signs that need to be investigated as soon as possible. So some of the nursing management issues are going to be ultimately to provide education and support to the family and child. There might be augmented hearing devices like hearing aids and communication curriculums so that the child can develop hearing and speech. Additionally, you might have to help with promoting effective communication and education, working with the child, maybe with instances of sign language, or maybe the use of text telephone service. Bells and alarms in the home may need lights. Additionally, encouraging education for potentially early intervention. I did speak to you guys about an IEP, an individualized education, plan that might be required. And ultimately, there's going to be emotional support that's needed. Um, these sensory deficits are grossly impactful on young people's lives as well as on families. And so they need to be referred to resources and support groups. And ultimately, again, it's sharp assessment skills and also doing a very good job educating parents on what it is that they should be looking for. Thank you for your time.